Hi everyone, welcome back to my channel. I miss you guys so much. I haven't been filming again for some time. I'm literally just studying, working and sleeping. This is all what I do. I started night shifts at the hospital, so now it's playing up a lot with my sleeping routine. Like I would wake up sometimes 2 o'clock in the morning or 3 o'clock in the morning and I can't sleep, and then I feel like I'm crashing through the day. So yeah, like it's I started night shifts 2 weeks ago, and yeah, like I'm still kind of adjusting. I'm having 4 shifts a month so far, and then I'm also doing late afternoons until 11 o'clock, and then early mornings, like when I need to wake up 5 o'clock in the morning, leave home at 6 to start at 7 at the hospital. So it's been really hectic, but I've managed to have a new haircut. This is my natural hair, by the way. I have really curly hair, and I've got some fringe going on here, and I've got more layers, and I absolutely love it. This haircut is very similar to what I had when I was like 17 and 18 back in Ukraine, and I absolutely love it. It's so cool. I will show you in a small video somewhere here in the corner how it looks like when you blow dry it, which is absolutely different look and so chic and so elegant. And yeah, I love to wear it both ways. But today we have rain. We've been having rains actually for the past week. It's flooded again in Sydney, and I'm so scared that we will have the same situation here in Queensland, to be honest, because I remember last year I couldn't even go to work because of the floods. A lot of low grounds been flooded, and like the public transport was not working. You could not go with your car. So yeah, anyway, because of the rain my hair gets so wavy even more. That's why today I decided to leave it as it is after I had my shower, and I was like, yeah, I'll just leave the curls. But it looks to me like it's a 90s kind of style. It's so cool. It reminds me of my mom as well when she was young, because I look a lot like my mom. And yeah, I absolutely love it. So in today's video, I wanted to talk to you about handovers, okay? Handovers are very important. Okay, if you're new to my channel, if you are new to nursing in general, let's specify what the handover is. So, when you have a load of the patients as a nurse, whether you're EN or RN, you will be looking after a certain amount of patients, okay? When you start in your shift and when you finish in your shift, you need to do something called a handover, okay? So, when you start in your shift, for example, the person who is giving handover to you, it means they handing over to you their patients that they've been looking after them on their shift, and now they're giving you information about these patients so that you know what's going on, what's been done, why these patients are here, you know what's the plan of treatment is, and then you will be looking after these patients throughout your shift. And then in the end of your shift you will be doing a handover as well by handing over these patients that you've been looking after to the next nurse who comes in the next shift. So the handover is pretty much you sharing the information about the patients with another nurse, okay? Or you receiving information about the patients that you will be looking after from another nurse, okay? So what's included in a handover? Usually it's included diagnosis, why this person has been admitted to the hospital. Then it includes whether the person is for CPR or for med calls. Some people don't want to be resuscitated, but they would like to receive active treatment. But if they passed away, just passed away, they don't want to be resuscitated. Okay, so this is very important. So you will have that information in your handover. Then the treating doctor or the treating team, like for example in a general medicine ward where I work, we have surgical team, we have medical team, we have gastro, sometimes we have oncology patients as well, like for a short stay and things like that. Then you will have a background history, which will include what conditions they had or having. It could be physical conditions like hypertension, AF, diabetes, COPD, asthma and all of that. And also it could have something like a mental kind of disorders. It could be depression, like a history of depression, anxiety, maybe suicide and things like that, you know. So it will be all in there. And also at the bottom of it, sometimes we specify if the person lives home alone, or if the person lives, if it's an elderly patient, if the person lives, for example, with a husband and the husband is a primary carer. Why it is important is because if someone comes in with the fall, for example, that means that the primary carer might not be able to look 100% after them, and we need to consider maybe social worker in the end, you know, as a final goal, to see whether that person is safe to go back home again. So kind of like a living conditions. Okay, then you will have any assessments or tests that has been done. For example, if someone had a CT or MRI or UA or bloods or whatever, chest x-ray and all of that, so all of that will be specified where the assessment section is. Then you will have diet, so it will be specified what diet the person is on. Is it a full word diet, means normal diet plus thin fluids, or someone is on a easy to chew diet, or soft bite diet and things like that. Then you will have a mobility, and the fluids as well, because it's really important to hand over to other people, to other nurses, if the person is, for example, on thin or thick fluids. Because if someone is elderly enough and they have like dysphagia or any problems swallowing, they would be assessed by the speechy, dietitian and all of that, and they might be put on a thickened fluids. So if you're giving tablets and you're giving thin fluids or like free fluids to a person, that person might choke, might aspirate, which might lead to different sorts of problems. Okay, so this is important. Then you will have a section which is your mobility, so you will need to hand over information about the mobility. Is the person is independent in mobility? Is he one assist? Is he using a wheelie walker, or is he on a Sarah steady or a full hoist, or resting in bed because maybe the person had a fall, needs further assessment? He just came on your shift, for example, recently, so you're just keeping him resting in bed until the physio come, or the treating team and whatever, or the scans, CT will be done to see if the person has any fractures and things like that. Okay, so after mobility you will have care plan, or like not a care plan, I would say like a plan. What's gonna happen to this person, for example? What's the plan of care for that person? And usually it would be something like ongoing physio assessments, then like a reg review tomorrow, or MRI tomorrow, for example, or having colonoscopy tomorrow, so nil by mouth from today midnight, and before that will be on a bowel prep, for example. So anything that is scheduled to be done for that person will be in a plan section. So when you are giving handover, okay, you will be handing over this information plus things that you've been doing during the shift to that person, like any cares, if there's any changes in the medication, you will be handing over to that person. And when you will be receiving handover, the other person will be doing the same to you. Usually we have handovers on a piece of paper. They are printed out for every shift, not per day, but for every shift: morning shift, afternoon shift and night shift. And usually the team leader is doing updates, because sometimes like we can do updates too. We're supposed to do updates as a nurses, like if there is any updates in a care plan, we can see in the notes that the doctors put, or if the CT scan been done or MRI been done today, or colonoscopy or any other procedure, we can update in a handover sheet and just put the mark there, like an X mark, that it's been done. If the person is going to be discharged home tomorrow, we can update it as well. But sometimes we have such a hectic shifts that we as a primary nurse who's looking after that patient don't have time to do that. So the team leader on a ward, and we have team leader on every shift, they usually sit down and they update quickly any changes, any new care plans and all of that for the upcoming shift. Okay, so when you will be handing over your patients, you will always have your sheet from the morning, your handing over sheet, where you can put all the notes that you need to. So that will be like a memory sheet for you to see what's been going on with that person. Okay, because sometimes your shifts go really hectic and really busy, and you tend to forget things. Okay, and also it is important when you're receiving a handover, you will have a clean handover sheet printed out for you. When you're receiving a handover from another nurse, let's say you came in the morning and you are receiving handover from the night nurse, whatever she's telling you, it's already written there, right? Because they're updating it through the night. But any small details, what's been happening through the night, maybe someone started to have diarrhea, maybe someone had like became febrile, high temperature, you know, maybe someone became nauseous, maybe someone had a PRN endon. So just put it in, just write it in, you know, by hand in your paper, you know, in your handover sheet, things like that. So what is also important in the morning? Let's talk about this part. So I explained to you roughly what the handover is and how it's happening. Now let's talk about important things, what you need to do during the handover, that many people actually tend to forget, okay? When you come, let's say in the morning, let's talk about the morning shift, okay? You are the one who is coming for the morning shift and you're receiving patients from the night shift, okay? The first thing when you come in, what I like to do is to go into the room. In my ward, we have rooms where we have 2 patients, and we have rooms where we have 4 patients rooms, then 2 patients rooms, and either rooms where 1 patient is only in the room, okay? So if it's a 4, let's talk about 4 people room, I go in, and before the handover starts, before I check the charts, I go in and I say good morning to the patients. It's, if they are awake, it's always nice to greet them. It's just a polite, mannered way. And then I go and I check the suctioning on the wall, and I check the oxygens on the wall. Why it is important? Because in a case of emergency, a med call, very often we would use suction, and not very often actually suction, very often we would use oxygen, and sometimes we would use suction. If someone is vomiting, if someone has obstruction to the airways, you need to suction it out. But the oxygen is very, very common to use during the med calls, okay, because sets go low. And you know what? The most frequent vital sign that you will notice in deteriorating patient would be his respiration rate and his oxygen. Okay, so a lot of them will be on oxygen during the med call, so it's very important for you to check those before you start your shift, because the last thing you want to happen if the med call is happening, that your oxygen is not working on a wall, because then you have to find someone to bring the cylinder of the oxygen, and during the med call every second counts to save the person, okay? So I do usually those, I check those, and while I'm checking, of course, I might wake up someone because I'm going near the bed, so I would say like, hello, how you going, you know, good morning. I would say like, I'm new nurse coming up today to look after you, we're gonna have a handover now. Then I will go and I'll grab the charts and I will quickly check the charts. So what you will be checking in the chart, it's basically like QS score. If someone is scoring 0, means great. If someone is scoring 1 or 2, just have a look what it is. Maybe someone got a hyper or a hypertensive during the nighttime, maybe someone got febrile, maybe someone had a high respiration rate or something like that. So I usually check the keywords. Then I will check if the person, like any charts, if the person is on a food chart, behavior chart, bowel chart. I would usually check if the person been opening bowels. So it's like one of the first charts, and see if someone hasn't been going to toilet number 2 for 2-3 days. It's straight away rings the bell to me to probably have a look if the person has any laxatives written, appearances like a Movicol, Caloxylin Senna and things like that. And if not, if it's not something regular, then it would be something in PRN section, so that I will flag it to myself to make sure to give it to that person in the morning. Then I would go through the med chart and I will check if all the medication from yesterday night, sometimes like we have doses of antibiotics given at 12 o'clock at night, if the BGL was okay, you know, if everything has been signed off. And if someone has diabetes which are managed by insulin, if someone is on a regular pre-meal insulins plus the sliding scale, I usually take out the chart and I pin it up, because this is first thing you will need to do right after handover, because the breakfast comes at 7:30, so you have to give insulin at that time, okay? So you have to check the BGL, so you have to check the sugar level. So I usually pin that one up, and I make sure when I'm checking the insulin chart, I'm making sure that the order is written for today, because sometimes doctors forget to write orders for the next insulin intake for the next day. And then you realize this in a time of giving insulin, you're like, oh shoot, it's not written for today. Like, let's say today is 16 and the last day there is 15, so I can't give it because it's not written for today. And then you have to chase the doctors, and they have in a handover at this time, like 7:30. This is when they come in. They have in their own huddle and handover there. So like, it's really hard to actually bring them to the ward. So I check that, and then I go and check if there is any fluids written, like normal saline, Husman or glucose or whatever, potassium, anything that's, if there's anything written for that person and if it's been signed before, okay? So you go through all of this quickly, and then you start your handover. So the best way that our facilitators, because we always have frequent auditing in our ward and in all wards in the hospital where I work, and I think this is how it works in general in Queensland Health. The auditors, it's like a CNs and facilitators who come and they check whether the nurses are doing the right thing. So they always tell us when they come to audit us during the handovers that the nurse who is giving handover, it's the best practice to hold the chart in their hands, going through it and talk about that patient, referring to the chart, like mentioning that, okay, this person had a Q at 0, and if it was not 0, if the person has been hypertensive, what has been done. Let's say someone was hypertensive, scoring, let's say 170 plus for their systolic blood pressure. That means that they will be roughly sitting, I think, if my memory is okay, probably 2, okay, sitting at 1 or 2. I think over 60 it's 1, and then over 70 is 2, so they will be QA'd in 2. Okay, so I want to know what happened after that. Okay, did you contact the treating team? Like, it would be at night, probably it will be not the treating team, it would be just ward call doctor, but did you contact the doctor? Are they aware that the patient been hypertensive? Is it something normal? Has the patient been hypertensive before? Was he in pain, for example? Because when someone is in pain, your blood pressure go up, your respiration go up, and things like that. So I would ask, okay, is the treating team happy that the person had QADs 2, for example? Sorry, I'm just waiting for my friend to come. Yeah, so if the treating team was happy, what did they do? Did they give any start dose of any antihypertensive medication? Did they say to monitor every 2 hours, for example? Now, was the person in pain? If the person was in pain, was any pain relief given? Was it effective? Things like that. So it's very important to go through the chart and actually say what happened, because we tend to forget things as well. Then she would go through the medication and would say, for example, okay, this been ceased, and now we've changed the dose, let's say, to like a higher dose, or the dose been decreased, or now it became PRN or something like that, that medication, you know. Or now the person is on additional pain relief in PRN section, you know, or if the person was feeling nauseous, or if there's some medication for a review, they will just point it out for you, things like that. So it's easier and more effective way to go through the chart with you while they're doing handover. Also, don't forget, when you're doing a handover, as I said before, greet the patient, just introduce yourself, say that, hey, my name is Yana, good morning, how you going? We're just going to have a handover now. We're gonna just talk a little bit about you and what's been going on through the night. I will be looking after you today. If you have any questions or you have something to add when we finish a handover or during the handover, please feel free to do that. Always make sure that you acknowledge the patient, you let them know what's going on, what you're doing, and also remember to add them into your handover. Make them feel like they are a part of it, because you're basically talking about them. So if they have anything to add or ask, they can do that. Usually they wouldn't ask many questions. Sometimes, most of the time, they wouldn't even ask anything, you know, but yeah, but it makes them feel like they are part of the process. And this is how it should be, okay? So yeah, what else I wanted to say? I think this is it pretty much. I think I covered it all. I didn't have any notes for this topic, but yeah, if you have any questions about handovers, please leave them in a comment section below. Maybe I did forget to mention something, and you maybe have some questions from your placements when you were doing it as a student, and maybe something hasn't been covered, so you can ask me there. Also, when you do a phone call to a doctor, for example, if you have a particular question, or if you need a stat dose of medication to be charted, you know, for someone, there is a small handover as well on the phone. You can just like, you can call and say, hey, such and such from such and such ward, you know, I'm calling in regards of such and such patient. Just tell them full name and bed number. Are you looking after the patient? Yeah, cool. Yeah, this patient came with this and this diagnosis. Okay, this patient came with this diagnosis. He is experiencing, let's say, systolic blood pressure. He is experiencing hypertension at the moment. His systolic blood pressure okay, would you like to chart a stat dose? So just, you give a small handover on a phone as well, just letting them briefly know and remind them who the patient is. They usually have their own handovers there, or like in a system that they can look. Yeah, so that's just a quick handover on the phone. Anyway, I will be going now. If you have any questions, leave them in the comment section below, and I will be happy to answer you guys. And yeah, I'll see you in my next videos. Bye.